Let it roll.
Did I hear a celebration when I said last two?
Yes.
It was actually said abduction.
I thought so.
Abduction.
Supine form. Patient position is supine. You want to first orient to your patient's ASISs. So palpate them right off the bat. Let your patient know that you might need to have him or her put a finger on them again. It's going to be kind of similar to doing hip flexion in that capacity. Starting position, again supine. Our fulcrum is going to be the ASIS on the side we're testing. Our stationary arm is going to be an imaginary line extending between the ASISs. So, fulcrum is on one ASIS. The stationary arm is an imaginary line between them. That being the case, our starting point is 90 degrees. Anything that we do movement-wise, you're going to have to consider that we started at 90. So if we move from 90 to 50, we had 40 degrees of motion one way. If we move 90 to 130, we had 40 degrees of motion the other way. But 90 is our starting point. Please remember that as you read out your measurements. To do abduction.
We spoke about two landmarks, the ASIS for fulcrum and the other one for
The horizontal line between the ASISs.
How about the third landmark?
Third one is going to be the anterior femur, anterior midline of the femur, leading to the anterior aspect of the patella. So orient your moving arm to the center of the patella. You're going to grab your patient's, again, provided there's no knee pain, distal tibia and fibula. Doing a couple things with that hand. Number one, it's going to provide for motion. Number two, it's going to prevent any type of rotation. If we allow that leg to externally rotate, we're going to bias our number. So make sure you keep the toes as well as knee pointed straight up toward the ceiling. Stabilization is going to be toward the midline, right inferior to the iliac crests, and we're going to abduct. Once you've maximized your patient's hip abduction, you're going to start to see the pelvis try to side bend. Or, do you have any hip problems?
No.
If you don't stabilize properly after the pelvis side bends, you might see the trunk start to rotate or flex. So make sure you stabilize properly, and once it starts to go, you've maximized your range of motion. We're going to assume about 40 degrees. So we're going to go from 90 on our goniometer to 130. Again, my distal arm is not only moving her leg, but keeping it from rotating internally or externally. Hold your position once you've gotten your end range. Can you put one finger on each ASIS? And she is right at about 130 now, which translates to 40 degrees. 130 minus our starting of 90.
Are you waiting for anything to push into the hand?
The hand
Or
is
you just
blocking
looking?
motion, but when I can't move the leg any further without that motion occurring, that's the point. So it's blocking, and it's also a cue for you as the therapist to feel when it starts to happen. Doing abduction. Patient position is the same, but you want your patient close to you on the table. And you want to abduct the contralateral leg all the way away from you. Same landmarks as before. Except now I want you to stabilize, again, inferior to the iliac crest, but you're going to push a little upward. When you see that the pelvis starts to tip downward on your side, you've maxed out the range of motion. There's a firm end feel there. It's probably about 30 degrees. So if our starting is 90, I'm going to put my goniometer at 60 degrees. Again, stabilizing, pushing superiorly on the iliac crest, bringing the leg inward. And once I can't stabilize it and it starts to push down into my hand, that's our end range. My final goniometer reading says about 78. What's that mean?
78 minus the 90, or plus the 90 start,
12 degrees.
minus.
Left